But even if you don't, I promise you that you get these questions a lot from family members that you really don't care if you're taking care of kids or not. You're still gonna get these questions. So I think it's always good to kind of go through these informations a little bit. All right, so the main topic today is just kind of focusing on how do we approach obtaining a history for patients, for children with fever. All right, let's share my screen. Can you guys see my screen okay?
It's good.
Alrighty. All right, so I think the biggest things when it comes to fever is a debating what is actually a fever, right? Different people define fever differently. But this is the scientific one that we used. It's very different depending on the method of measurement. And it's also have a little bit of a different definition depending on the age group of the patients. But in general, I think everyone agree that a core body temperature above 38 degrees is usually considered a fever. All right. So I'm sure you guys are familiar with OwnCard. OwnCard is the typical kind of mnemonic we use to obtain history from patients with a general pain complaint, right? Headache, chest pain, abdominal pain. But for fever, those mnemonic doesn't work very well because it just you cannot really characterize or describe a fever just like how you would describe a pain. Especially for children, they don't usually give you a lot of kind of information about how they're feeling. They're usually not very great with describing. And when you're dealing with very, very young children, it almost becomes impossible to get those information from them. So what we use is a little bit different. So I use what I call most dear, not the most grammatically correct English, but it's worked for what I need to use. So it includes method, onset, symptoms, treatment given, and then a couple of triage questions that I use. So drinking, eating, activity, and then is there any risk factors or red flags that we need to worry about? All right. So measurement of methods. Why is it important? Because as I mentioned above, the definition of fever change depending on what your measurement method is and depending on what your patient group is. So this is one of the most common way we would measure temperature in children. So tactile means that you just touch the patients and it feel warm to your touch. That called tactile, okay? So temporal is using infrared to measure the temperature in the forehead. So temporal is the bone in your forehead, and that's why we call them temporal. Tympanic is measuring the temperature in the auditory canal. Axillary is probably the most common way you will see temperature to get taken. Another common one is oral. And then the last one, which is usually the most recommended one for like infants and neonate, is actually rectal temperature. And this is the most accurate core temperature that you can get. So that's that. All right. So the next questions, and what I feel like is the very important question to ask, is onset. All right. So how long has the fevers been going? And it can vary, right? Some parents have a very low threshold to calling the physicians. So sometimes it's just a few hours. Some parents has a much longer threshold before they need to seek medical care or go into the emergency room, so they can wait for days. So the biggest question for us as medical providers is, how long is too long? Like, is having fever for 2 days dangerous? 3 days dangerous? What is the cutoff, right? So in general, in pediatric, a fever for 5 consecutive days is an absolutely concerning symptom that need to be seen by a medical provider immediately. And then you guys know, just throw it out there. Do we know why it's so concerning for pediatric? It's probably a little bit more correct for the US, for the Western countries as compared to Vietnam. But I'm just gonna throw it out there to see if anyone have any idea or thought on why 5 days kind of like a concerning sign for us. Any pediatrician out there? If I remember correctly, in Vietnam, I remember when I was in, I think, elementary school, middle school. Remember, there's a saying that if you have a fever for 3 days, you need to see a medical provider, right? So what are they worrying about in Vietnam for fever for 3 days in a row?
Oh my.
Yep, go for it. You guys feel free to unmute and talk. You don't have to raise your hand.
Yes. In Vietnam, maybe 3 days fever. They maybe concern then fever then. So people maybe to go to the hospital to have a blood test to check. Okay.
Yeah, so I think I understand what you say. So the condition called dengue fever, so it's DENGUE fever or subsequent. Well, yep. All right, so that's what usually is the concern in Vietnam. Dengue fever is not that common in the US or in the Western country. So the 5-day cutoff that we use for kid coming to the emergency room or coming to a clinic to see a provider is for Kawasaki disease. And we can talk a little bit about that in a little bit. And can you type out the word Kawasaki somewhere in the chat box? Thank you. All right, and then, so the next step is any fever that lasting more than 8 days is becoming a fever of unknown origin. But that's just like a common terms that we use in pediatric that so you guys get familiar with. All right. So the next one is the T, which stands for treatment. It's, for us, it's very important because fever, as I mentioned, is very common in children, and most parents, especially like second term or third term parents, they can handle fever without like hesitation. So most of the time, you will see a kid who already received some kind of treatment for fever at home. And it's important to know so that when you examine your patient or when you're assessing your patients, what you are seeing might be different, might be masking because the kid already received treatment right before they see you. And that's why the kid looks great. So the common question you ask is, what did you give them? When did you give them? And how much did you give them? All right, so to answer the what question, so antibiotics, which is the scientific name for fever-reducing medication. The most common that we use in pediatric is ibuprofen or acetaminophen. So the brand name is in the bracket for you guys. So Advil and Motrin is the common brand name in the US for ibuprofen. And then Tylenol is for acetaminophen, which I think is equivalent with our paracetamol in Vietnam. Another medication that sometimes get brought up for fever is aspirin. You absolutely do not give aspirin to children, okay? Unless there is a indication, and really the only time I ever give aspirin for children is for treatment of Kawasaki. But other than that, do not give aspirin to children. It's associated with a condition called Reye syndrome, and it's dangerous and life-threatening, so we do not give them to children. And then, so going to the next question is when. So when is the last dose that you give medication? And as I mentioned, it can kind of changing how you assess the patient because the medication might have masked some of the symptoms that you're seeing. And then the last one is how much. medication in pediatric is always weight based. So it's very common that parents will underdose or overdose a kid. So that is very important that every time parents self-treat their kid at home, you need to making sure that they're actually giving the right dose of medication for the kid. Because I got a lot of like complaint for parents when they come to the emergency room. It's like, I give the medication at home, but the fever never broke. But then they come to the ED and the physician give the same medication and the fever like gone away. So like the difference is that they underdose at home. That's why the fever stay. We give them the appropriate amount of medication. That's why the fever goes away. So it's just making sure that you educate patients on the appropriate dosing for the children. All right. And then the next couple question is very important, and especially for those who work in the emergency room or happen to be in clinic late at night when you have limited capacity to examine patients. Because this will be the main one determining whether or not you're sending the kid to the emergency room, you're admitting the kid, or you're sending the kid home. All right. So making sure that the kid is drinking, because children are very prone to dehydration, especially a child with fever. They usually don't feel well, they don't want to eat, they don't want to drink, and they have increased insensible loss because of the fever. So they are at very high risk for dehydration. So we always assess that. For older kids, you can ask how often have they been going to the bathroom today? Is their urine look darker to you? For younger patients who's not toilet trained, the most common way to ask is how is have the baby been making regular wet diapers? How many wet diapers in the past 24 hours? When was the last wet diapers that the baby had? And how heavy is it? Because sometimes baby can have the normal amount of wet diapers, but the volume of urine is significantly reduced. So that's also another concerning side for infection, for dehydration. And then next one is eating. As like, again, when children have fever, they don't feel great, they don't like to eat. And it's also, sometimes they might not be able to tell you that they have nausea. They just refuse to eat, right? Because they don't feel well. So asking about how have the kid been eating? Have they been able to eat anything? Are they able to keep anything down is also very important. And then the last one is activity. So this one in pediatric is probably one of the most important questions you need to ask for every kind of chief complaint, to be honest. A healthy children is a playful child, right? They happy, they interactive with you, they play, they're running around. When they don't feel well, they just don't do anything. They just lay still, they refuse to play, they refuse to interact with you. And it's also a very good way to kind of assess the mental status as well. So that's why it's always important for you to kind of ask those questions. All right. And then so risk factor. This is particularly important in pediatric. It's just similar to in adult, you ask their medical history, right? For in pediatric, their medical history tends to be on the lighter side, but there are a couple of things that can affect how we approach their management significantly differently. All right, so if the birth history is very important, because if the baby was born premature, if there's a significant developmental delays, you have to manage the patient differently. And medical history, just like an adult. And then this one is particularly important for fever, is the immunization status. A fever in a child that is fully immunized is not a medical emergency, but in a child that is under or unvaccinated is an absolute medical emergency. You have to treat it as serious bacterial infections until proven otherwise. So that's why it's very, very important for any pediatric patient that you know what their vaccination status is. Sick contacts can sometimes give you a clues of what kind of potential infection that they get exposed to. Daycare attendance is another one, because they usually get, like, daycare is like a petri dish, right? Everyone gets sick there, they bring the germ back home. So it's also kind of give you an idea of where the potential sick contact come from. And then sexual activity, especially for younger teens, right? So in America, we started to ask these questions around 12, which seemed ridiculous in Vietnamese culture, but it's just that how the society has evolved in the US. But I would recommend starting to ask them, like, especially like toward high school, like later middle school or high schooler. Right. And then the last one is kind of trying to cover everything. Is like any other symptom that comes with a fever, right? Fever is just a symptom. It's not really specific to any kind of conditions. Usually the diagnosis will create other symptoms, and that will give you a clues on how, like, what the diagnosis is and how you would manage them. All right. And so how do you ask that? So in the US, we ask those through a series of review of system questions, or ROS. So this list, I list all of the things out there. This is a very extensive list. You, as a physician, don't have to always ask the whole list. You have to base on what your patient is, what your history you got so far, what the chief complaint, and kind of tailored it accordingly. So usually, if you have really high concern for meningitis, then you will focus more on the CNS or central nervous system questions as compared to, like, for example, GU system. So you just have to kind of adjust the list of these questions according to what you think is what is your differential diagnosis, your working diagnosis is. So we'll talk about how to approach them. And then this is just a list of the common causes of fever in children. And I deliberately separated into two different age groups because neonate has a significantly different risk factor. So we managed fever in these populations a little bit different than the toddler, children, and teens. The most common cause of fever in any age group is usually viral infection. So common cold, RSV, flu, COVID, etc. In the neonatal sepsis is higher risk compared to children and teens because they just born, they can acquire the infection on their way out or in utero. So we usually have a little bit higher index of suspicions for these kind of infections in neonates. So we have what we worry about is bacteremia or bacteria in the blood, bacteriuria, bacteria in the urine, or sometimes we call them UTI or urinary tract infections. And then the last one is meningitis, is the bacteria in the CSF. All right, and then so for children and teens, the common bacterial infection that you will see is ear infections, strep A, pharyngitis, pneumonia, UTI, and then again, sepsis, meningitis. And then especially for teen, you have to think about sexual transmitted disease. All right. Who's here familiar with mommy calls? At least know what mommy calls is? Because you guys, I watched a couple pre-class exercise, and you guys did, you guys played out mommy call perfectly, and I was really impressed. So, so for those who doesn't know, so mommy call is a concept in the US where all of the pediatrician office has a special on-call phone number that, after hours, if parents have any concern about their children's health, they can call that phone number, and there's always going to be a physician's on call to check those calls and kind of help reassure parents or give them advice or direct them to go to the emergency room if that is indicated. And as part of being a pediatrician, this is what you have to do. So you have to check mommy calls. And sometimes it can be something very serious, like, oh, my kid cannot breathe, or it can be my kid has a hiccup at 3 o'clock in the mornings, and I'm just worried. I have got like, my kid have not go to the bathroom for a week, but now I decided to call you at 2 o'clock in the morning because now I'm concerned. We get those random calls all the time. So that's usually a running jokes in the pediatricians. That's like, what is the most ridiculous mommy's call you ever get in your career, kind of thing. All right, so we're gonna do a little quick exercise of mommy's call for you guys. Okay, I want you guys to kind of yell out what you guys think. So you are at home sleeping. This is 2 o'clock in the morning. You got a phone call, and this is kind of the one-liner that the mom give you. And I want you to think, where do you think the baby need to go, or the patient need to go? Is it a case for the emergency room, or the patient is stable enough that they can wait until tomorrow for clinics? Okay. All right. So the first one, you have a 2-day-old with 1 hour of fever. Where do you think this patient need to go? Is it good enough to wait until tomorrow, or does have to go to the emergency room right away? And again, feel free to unmute and shout out.
Well, actually, I believe this case, the mommy have to pick the children, go to emergency room.
All right, I have one vote for emergency room. All right. Anyone else for emergency room? Or someone think that clinic is fine?
I think 2-day-old with 1 hour fever can wait for clinic.
All right, so we are even now. 1 and 1, 1 emergency room, 1 clinic. All right, someone break the tie for me.
We will have some advice or antibiotic first before go to emergency room.
All right, so I got give them some medications and then go to the emergency room. All right.
I think
Yes,
I think in neonates, a baby with 2 days old within 1 hour fever, mother must give her or he to emergency room, because maybe some infection, neonatal infection can be occurred in this child, like meningitis. And
yep. Yeah. So yes. I think kind of it sounds like the majority think this kid need to go to the emergency room, and I agree. So for me, a 2-day-old with fever is an absolute medical emergency, and you have to treat it as a serious bacterial infection until proven otherwise. So and then this is unfair for those who's not in the pediatric field, because you are not familiar with this guideline. But for the general guideline is that any kid less than 60 days who has fever should be seen by a medical provider immediately, and anyone less than 28 days should have a full sepsis workup. So blood culture, urine culture, CSF culture, all of those. So that just kind of for you as reference. So if in case you have a friend or a family member who have a kid that is in this age group and have a fever, that kid need to be seen in the emergency room or seen someone immediately. All right. So moving to the next one, you have a healthy 4-year-old with fever for a day. Go to the emergency room or wait for clinic tomorrow.
I think the mother can wait for clinic.
All right, so 1 vote for clinic.
The type on the keyboard then is type E for emergency or C for clinic.
Yep, yeah, anyone who doesn't want to talk, and feel free to type it out. I'll let admin tally up the thing.
Okay. Quick. Okay, we have zero C here.
Yep. All right. So this kid can definitely wait. So this is the most common cause of fever, especially like just 1 day fever for a healthy 4-year-old is most likely a viral infections. So this is not an emergency. This can be seen in the clinic tomorrow, unless you have some other concerning sign that the mom mentioned to you. All right. But actually want to run. There we go. All right. Next one, 8-year-old with fever and a sore throat. Emergency room, clinic.
Okay, again, C or E. We have all C so far.
All right. Yep, I got a lot of C. Agree. Clinic. This kid probably have either a viral pharyngitis or maybe a group A strep pharyngitis. Those can wait. Perfect. All right, so next one, an 8-year-old with fever, sore throat, and stridor. So for those who doesn't know stridor is a noisy upper airway sound that you hear that sound like snoring a little bit. I got a lot of emergency. Great, excellent. All right, so the reason why they need to go to the emergency room is stridor is a concerning sign for impending upper airway obstructions. So that kid needs to be seen. All right, next one, 18-year-old with fever and a headache. Clinic, emergency. I got 2 clinic, lots of clinics. Excellent. 18-year-old have fever and headache, probably a viral infection or maybe a flu. So that can weigh into clinic. All right. And the last one, same story, but now they complain of a neck stiffness. All right, lots of emergencies. So why are we worried about that little neck stiffness? Does anyone know what are we worrying about?
Yeah, can I go?
Yep,
Can I go first? Yeah. Yeah, because the neck stiffness size that indicates that the patient might have the meningitis.
Excellent, bingo. There you go. So neck stiffness is a concerning sign for meningitis, and that's why the kid need to be seen right away. Okay, so all of the things that we've been talking about that help you decide that kid need to be seen right away is what we call red flags, and that's what we're gonna talk about next week. And so for now, any questions? If not, I'm gonna let you guys hop on to the practice part.
Okay, terrific. Thank you, Sarah.
Yep.
Let me share my screen for the breakout room. Okay, just a reminder how to get to the breakout rooms. And if you have to leave the breakout rooms to come back, you click the leave button. Oops.